Hi, and welcome to the show, where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Today on the show, we have Taimur Safder. He is a cardiology fellow, and he wrote the Kevin MD article, "It's Time to End Draconian Hospital Visitation Policies During COVID-19." Taimur, welcome to the show.
Thank you, Dr. Poe, for having me.
We'll get into your article in a little bit, but first off, can you share your story and your journey to where you are today?
Yeah, absolutely. I feel like it's a very long one. I actually was born in Pakistan, but came to the States at a very early age. We came straight to Kansas, actually. So I grew up in Kansas for most of my life. I ended up staying there for my early training, med school, and residency at the University of Kansas. And then after residency, I was interested in public health policy. So I went to Boston to do a year to kind of explore my interests there. And then I came to Dallas, which is where I'm at right now, to do my cardiology fellowship. Almost done, a few months left. I'm a third year. I'm heading to Chicago actually next to do my advanced imaging and cardiology training for a couple of years. So it's 11 years summarized in a few seconds.
All right. Well, best wishes on the remainder of your medical education journey.
Thank you.
So we're speaking in the middle of February, and from a COVID-19 standpoint, tell me what you're seeing through your lens as a cardiology fellow.
Yeah, I like to divide it up into inpatient and outpatient settings because we often do both. From an inpatient setting, the hospitals are doing their best. I feel like as a trainee, you get a different taste of what's going on. They're trying to protect us as much as they can from exposure. So, mostly I see them on the consult service. And so we're seeing a lot of like troponin elevations, which a lot of times we don't know what to do with in terms of, there's a lot of unsolved answers as to what does it all mean? Is it inflammation? Is it myocarditis? Is it some sort of MI, whether that's type 1 or type 2? So often we don't have a lot of answers for all of these consults, but I would say that's kind of the most of what I'm seeing in inpatient is just troponin elevations. And then there's some questions about, early on, I don't know if you remember about ACE inhibitors and some of these medications, questions about should we keep them on, should we keep them off? So we're trying to help with that decision as well. Often kind of the severe end of the inpatient side is often a cardiogenic shock. In that sense, we're seeing that, but the treatment from that standpoint is not necessarily any different. So we're trying to manage the best we can. We don't have a lot of data, a lot of evidence to guide what we're doing, but we're trying to do it as best as we can on the inpatient side. On the outpatient side, a lot of it is turned into telemedicine, and which I'm sure is similar to a lot of other fields. So we're seeing a lot of patients through telephone, through video encounters. And for cardiology, for some aspects, it's not that bad because a lot of it depends on history. If you're talking about arrhythmias, but if you're seeing patients with heart failure, it becomes a bit more difficult because we do rely on a good exam. So that aspect is a bit more difficult from that standpoint. And then there's also this other idea of a lot of patients aren't seeking care. So we're seeing some complications from delayed seeking of care from a patient perspective. So it's kind of like we're seeing a lot of different things. And I think we probably won't see a big portion of or a large aspect of this until later on, maybe months, years down the road.
So from a cardiology standpoint, what are some dangers of delaying your cardiology appointment?
Yeah, early on, what a lot of the hospitals were reporting, I think this was fairly universal across the country, was STEMI cases were going down, and so a lot of the most logical explanation of that was thought to be that patients aren't seeking care, especially early on in the pandemic when there was a lot more uncertainty. And so the idea was that we're going to start seeing the late complications of MI, whether that's valvular or whether that's cardiomyopathy. So that's the thought was that we're going to start seeing these complications of MIs down the road. The thought was also that we're likely going to see more cardiac arrests as patients with cardiomyopathies or heart failure aren't seeking regular care. I personally haven't seen as much of that, but I think there's still some observation studies going on to see if that's the case. But that's kind of some of the stuff that we are assuming that we're going to end up seeing is a lot of consequences of delayed care from a cardiology standpoint.
All right, so let's transition now to your Kevin MD article that you wrote. It's time to end draconian hospital visitation policies during COVID-19. Now, for those who didn't read the article, can you just walk my audience through it and share the story of why you decided to write it?
Yeah, absolutely. So, this concept of this article started really when during my inpatient rotations early on when I started noticing small things, some things we get so used to when we see patients and their families by the bedside. Yeah, whether that's just, when the patients are trying to minimize their symptoms and the family member will speak up. So I started to see how we're kind of missing that when the hospitals initially just went completely strict and no visitation for any sort of things were allowed. Even when patients were dying, they weren't allowing anything. And then as the months went on, I started to see how this was really affecting not just like the emotional stability of the patients and how they didn't have the support, which they often relied on, but also a lot of times the care that we were providing, whether that was, a couple of examples I mentioned in my article, a patient with delirium. Often we rely on family members to keep them, with their attention and oriented. And so we started to see some of that. And then in terms of cardiology, often we see a lot of patients that are on a lot of medications. Polypharmacy is something we see all the time. Someone comes in with a heart attack or heart failure, new diagnosis, and suddenly we're sending them home with 5 or 7 new medications. And family members are a big part of keeping, them sane in terms of going through all of this and keeping them on the track. And then we started seeing that we couldn't do that as well, just on the phone. And so I started to see how this was actually affecting the care that we were providing. And then just talking to colleagues, just say there was not just on the side of physician, but also on the side of the other side where some of my friends were having their family members, whether they were grandparents or parents, in the hospital, and just how odd that felt and how powerless they felt, even though being doctors and being so well aware of the system. And then I had, I explained in the article how I had a family member who went into the hospital and had a similar feeling. And then I finally decided to, write something about it. And I've had great positive feedback. I've heard from multiple people how, they're glad that someone's finally wrote something about that, read something about that, because it almost feels like a little bit of a taboo, like nobody wants to contribute to worsening the pandemic, especially as healthcare workers. But at the same time, I feel like the discussion needs to be had about, what are the benefits and risks of allowing at least one family member, especially with kind of the context we're in now.
So as far as you know, in the hospitals in your area, are there strict no visitor policies in place right now?
Yeah, so as trainees at academic centers, we often work at multiple hospitals. For example, I work at the VA, I work at our major hospital, and so it's very different. And that's one of the things I also note that the CDC is not really giving any clear guidelines on what should be. So every hospital is left on their own, which is probably good because regional infection rates and is probably different. So it's best if you base it on that. So like our VA is really very strict in any sort of visitation policy. They're not allowing really anyone. Or says our major hospital, Baylor University, it's a bit more, it started off very strict, but now it's starting to allow one visitor for a certain sort of like number of hours. And even that small allowance has made a big difference, I think, in our patient care. So one of the things I implore in the article is we can't just do one size fits all. We just need to evaluate every scenario, every hospital, every region. There should be more flexibility in what we're allowing.
So as far as, have any studies been done looking at the potential correlation between community spread and hospital visitation policies?
That's a good question. And no, my understanding. So I know the data from in terms of there's been some studies that have showed how much of the infection that spread is hospital based or intra-hospital based. There was a few studies came out of Wuhan initially that showed that most of the transmission, most of the healthcare workers that tested positive were actually got it from community, not in the hospital. And then a couple of studies since have shown the same thing, where a lot of the infection that hospital personnel get, they're actually community-based and not from the hospital. And that makes sense too, logically, because one of the places that we're really, really good at in protecting ourselves is in the hospital. We have the best resources. We have, PPE now is very, very much available. And we're a really high guard in terms of we're really looking out for it in the hospital versus we let our guard down when we're in the community. So it makes sense both logically, and a couple of studies have shown now that that's probably the case. So I haven't seen any specific data, clearly stating that, hospital spread and letting visitors in, but I know there's been some studies showing that most of healthcare personnel get infected are often gotten from community setting.
So in your opinion, what should be the trigger for hospitals to relax their visitation policies?
I think that there should be a clear criteria. One would be every patient scenario is different. And so obviously the more urgent or critical condition a patient is in, I think that should be looked at differently than someone that's just coming in maybe for something that's elective or something that they may go home the same day. Also, I think the patient characteristics should be looked at. Is there a patient that needs, maybe younger patients or older patients that are more in need of someone in support care, maybe patients with, psych illness. It doesn't necessarily have to be, something severe as schizophrenia, maybe just anxiety, maybe patients who just have, some sort of issues with dealing with all the stuff that we do in the hospital. Such a high level of mental acuity, I feel, is needed in these scenarios. And certain situations, new diagnoses that are heart failure, MI, something that's more critical. So I feel like patient characteristics, their health characteristics, all these things need to be taken into account. But also, I think regional characteristics would be important to take into account. Like if you're in LA, where the rates are much, much higher, maybe you're a lot more strict in what you're allowing. But maybe if you're in a different area that the rates aren't as high in the community, maybe you are a bit more flexible with what you're allowing. So I think it has a combination of everything. I don't think there should be any sort of blanket policy one way or the other. But I just think that the mindset of most friends I've talked to in the hospitals across the country, they seem to be just very, very inflexible.
We're talking to Taimur Safder. He is a cardiology fellow. He wrote the Kevin MD article, "It's Time to End Draconian Hospital Visitation Policies During COVID-19." Taimur, you mentioned that you had a lot of positive support when you wrote this article, and I'm hearing the same thing as well. Now, are you hearing anything from the flip side? Are you hearing about anyone who wants to continue these strict visitation policies?
Yeah, that's a great question. I was actually kind of concerned about that when I first wrote it. And, so far, no. And I have heard only positive messages, but that could be a result of being kind of in an echo chamber, maybe, because mostly I'm hearing from friends and colleagues, and I'm sure they're less likely to give any significant criticism. There's been a few comments on the piece online, and those were all supportive as well. So I haven't gotten any, significant pushback, which I was expecting, but so far I have not.
And what about from hospital or medical institutions themselves? Do you know what their reasons are to continue these policies?
I've talked kind of off the record to some of the admin people, but I haven't gotten any sort of clear answer. But I think a lot of it just has to do with everyone's just overwhelmed with what's going on. And it's really difficult to just deal with the normal challenges that this pandemic represents and presents to a lot of hospitals. On top of that, tier on all these other complexities, like what do we do with visitation policies? It's such a complex issue, and to layer on, we can do this with this scenario, when they're just struggling to meet the normal demands. I think it's just a level of complexion that maybe we're not ready to handle. But I feel like now that we're kind of on the back, I don't want to say back end of it, but at least kind of somewhere where we feel like we've somehow got a little bit of a handle on the situation. A lot of hospitals have universal testing policies, so we're testing everybody that comes in. So now I feel like we have measures in place where we can start talking about this, where hospitals should feel comfortable talking about what are some of our policies that may not be. Because I think it was much easier just to have a blanket policy initially, but I feel like now is the time to start this discussion. And I'm hopefully going to go back to some of our administration and talk more about these issues.
And my final question, what's your take-home message that you want to leave with the Kevin MD audience?
Yeah, I would say that I would go back to my experience with the family member in the hospital and what I would say was the feeling I had was, it was a very powerless feeling sitting at home with a family member sick in the hospital and trying desperately to get a hold of someone. What I didn't include in the hospital was how many times we called the ED and we didn't, we barely got a response. How many times we called the nursing floor when our family member moved to the floor, and how difficult it was. And I'm on both sides of that. I know how busy it is on our side, and it's really hard. The healthcare systems ask a lot of us, and I get that. But I feel like I would just like to leave with that message that in those moments, just try your best to take that extra moment to reach out to a family member, especially in these times, because we're so far removed from that situation now that the family members need better and clear communication more than ever. So I would just implore our side of the healthcare workers just to take that extra step, even though we are very, very overworked.
Well, thank you so much for sharing your time and insight. And thanks again for being on the show.
Yeah, absolutely. Thank you for having me, Dr. Bo.